Hello, everybody. Um, for the remaining taped lectures of this course, there are going to be two. One is going to be the overview of the minimum data set form and talking a little bit about the survey process. And then the second online lecture will be about quality indicators. There is noted on the syllabus about talking about assisted living, personal care, home, and hospice. We'll actually talk about that when we do our in-class long-term care lecture. So we also remind you we'll be having the chat session next Tuesday, November 8th from 7. It'll start probably about 7:10, 7:15, and it'll go to 8:15. And we will be reviewing the case from a couple weeks ago and just seeing if anybody has any questions overall for the course. I will send out announcement of the go-to meeting later this week, and then I'll send it resend it out again um, Tuesday morning to remind you. Okay, so one of the things that in one of the prior folders, when I sent the folder with the material about FTAG 425, within there is actually a sample of the MDS form. In fact, if you take a look here, um, this is it, MDS 3.0 recommended form. And we'll highlight some of the material that is in this form and explain what it is here shortly. Okay? One of the things is that nursing homes themselves always have to be looking for quality improvement, quality assurance, especially to make sure they're addressing all the different F tags. And we talked about the F tags in relationship to pharmacy, but there are numerous F tags that are related to overall patient care of the nursing home. And so the people that oversee skilled nursing homes are CMS, the Center for Medicare and Medicaid Services. There is a survey process done here in Pennsylvania and all states. Most of the time is the state's Department of Health that partners with CMS to do at least a yearly inspection, and this is done every 9 to 12 months. The other thing that is posted to help guide nursing facilities quality indicators, and we'll give that talk here shortly. It should be posted online for you, and quality measures, which kind of go hand in hand. So during what happens is the survey process, there's an annual survey by the state. Any of these investigators from the Department of Health or CMS can come in at any time if there's any complaints filed with the nursing home by anybody. So there can be inspections all during the year. There are also most survey processes follow those F tags that I talked about, the CMS, and sometimes the state may have more stringent. Here in Pennsylvania, we pretty much follow the CMS operations manual, and depending upon the severity of not being in compliance with the operations manual, the home can be subjected to fines and other penalties. Things that are looked at during the facility survey are pharmacy services, medication errors, how controlled drugs are handled and disposed, infection control, psychotropic drug use, how appropriately are these drugs being used? Do they have indications? Is there trying to taper these medications when possible? Looking at unnecessary drugs, and looking at how well the consulting pharmacy services is being done and how well it's being received by physicians. There also is a quality assessment assurance committee. This committee has to meet at least on a quarterly basis. I have found that nursing homes a lot of times will even meet on a monthly basis, and this is going to be looking at the various quality indicators, which please see the other taped lecture that is posted for this week. couple of the other things for the nursing facility requirement that each resident must receive and the facility must provide the necessary care and services to attain or maintain the highest practical physical, mental, psychosocial well-being and functional, I'd throw out there. So you think about the multiple components of a geriatric assessment, the nursing home has to meet those needs. And if you notice back here, it talks about plan of care. So every time a new resident comes in, or at least on a quarterly or yearly basis, the nursing staff should look at what is the actual care plan. What needs to be done for each individual resident to either improve their quality of life or maintain their quality of life. Some of the things that they look at that are mentioned not just in the F tags that we talked about, but in their other F tags is a drug that has to be delivered in a timely manner. So a drug, whether it's prescribed on a routine emergency or an as-needed basis, must be provided in a timely manner. If failure to provide a prescribed drug in a timely manner causes the resident discomfort or endangers his or her health and safety, then this requirement is not met. What is actually a timely manner? Well, most of the time in the policies and procedures of the nursing home, the timely manner will be what is appropriate for that person to start that medication. So, for example, a medication for an antibiotic for somebody who's severely sick, well, that should be started either right away or within a few hours. So, a timely manner could either be an emergency drug from emergency drug box or emergency delivery, or from the next time the pharmacy delivers medications. And most skilled nursing facilities will either have a daily or twice daily delivery. And this timely manner will warrant whether or not, what medications should be in an emergency drug box at the facility. The other thing, too, is like an example of a drug that is not technically a true timely manner is an antidepressant, although it is important to be started as soon as possible, as we know that certain drugs like antidepressants may take 2 to 3 weeks before they take effect. The other thing that the facility must provide medically necessary care, so there has to be a medical director, there has to be physicians that can actually come to the facility, and like I said, all medications must be administered in a timely manner, and we talked about MedPass and FTAG 425. The facility must ensure that it's free of medication error rates of 5% or greater, and residents are free of any significant medication errors. And that's the importance of the medication pass, that's the importance of the special packaging, that's the importance of supplying either electronic medication administration records or paper medication administration records. Delivery of new medications same day or next morning. Stat deliveries should be in 2 to 4 hours. There should be an emergency drug box, and the nursing home should use some type of specialty packaging, whether it's bubble packing, multi-dose, paper packaging, to ensure, excuse me, I have a cold here, I'm sorry, to ensure that this packaging is there to help provide safety, accountability, and prevent theft in the nursing home. One of the things about specialty packaging, it enhances the accuracy of administration, the efficiency, and especially specialty packaging allows accountability of controlled drug substances. Medications ordered in a long-term care facility, physicians are usually off-site, and so there is always like a three-way transaction where the nurse will call the physician if there's a problem. The physician will give the nurse a verbal order, and that order will either be faxed to the pharmacy, or a lot of facilities are now using electronic physician order. So there's usually a three-way transaction. Most of the time, the way nursing homes work too, traditionally in a community pharmacy, we're used to the pharmacist calling directly to the doctor's office. Most of the time it's the nurse that the doctor wishes to only speak to one person. Not that they don't want to speak to us, but it provides just one communication for them. So a lot of times your recommendations may be either being recommended to nursing that's recommended off to the physician. The other thing about medications in a nursing home that we always deal with formulary issues. The home may have their own personal formulary for Medicare Part A patients to help control costs. In Medicaid, at one time, most states used to have just one Medicaid um, formulary because we didn't have managed care. But as we know, like even in the state of Pennsylvania, there could be multiple managed care Medicaids like Gateway, UPMC for You, Coventry, and one of the things that we know in insurances, we have a lot of different things that may not be covered or a lot of things that may need prior authorization. One of the things is if a physician writes an order, it's an active order, and that timely manner thing falls suit. So say a medication needs prior authorization or it's not covered, you better in a readily manner get that medication either substituted or there should be a hold on that medication order written until that prior authorization so that is not an active order and the nursing home is not out of compliance according to state and federal regulations. Like I said, most of the time in a long-term care facility, you know, the nurse will call the physician if there's an issue, or the physician will call the nurse. Physicians do come into the facilities at least once or twice a week to see their residents. And then that all that stuff is recorded in the medical record at the nursing home, which is then facilitated to the pharmacy. So, like I said, it goes back and forth, and that's your communication process you see in the nursing home to take care of that resident. One of the tools that gets used that Medicare and the state uses to assess how well everything's done is a resident assessment instrument, and that is the minimum data set. What is in the minimum data set is a comprehensive assessment of the residents' functional abilities, their cognitive status, things that might have functional issues with them, such and disease states such as delirium, fall history, how well are their activities of daily living, their diagnosis, their wounds, their nutritional status, restraint use, continence status, and nursing therapy notes and other documentation should be reviewed to ensure that the MDS is accurate, because this is what gets sent and this is what the surveyors are going to use to base upon their assessment. The minimum data set for a consulting pharmacist is a great resource because I said a lot of times notes can be not that detailed in a nursing home, and the minimum data set is a great way to collect initial information or also see if there's any changes in the patient's health status when these are done, at least on a quarterly basis. So, the MDS functions is a comprehensive assessment. It's a basis for residents' care. It's a basis for payment. This is how, depending upon how they classify a resident, will determine what they get paid by either Medicare Part A, if they're a Medicare Part A patient, or a resident. It's also the basis for the development of the quality indicators and making sure those quality indicators are measured appropriately. So let's take a look at the MDS example that I told you that I posted here. So here's the MDS form, and I'm just going to highlight through a couple things. If you notice, here is the facility's information, the resident, their personal demographics. Here is, that this has to be done on admission, and it should be done by day 14, and then there should be obviously a quarterly review and an annual review. If there's any changes, if they're here as a Medicare Part A patient, this will be done on a 5-day and a 14-day scheduled assessment. If they're there any longer, most of the time the average Medicare Part A stays anywhere from 14 to 21 days. If they're there any longer, then it's done either a 30-day, 60-day, or 90-day basis. And these are requirements to be actually be paid by Medicare. This will determine, when they're staying. Like I said, a lot of this is demographics. Section B talks about any disabilities in hearing, speech, and vision. Section C focuses on their cognitive issues. Section D focuses on their mood. And so when we're talking about assessing patients for whether or not they need dose reductions in psychotropics or antidepressants, this is a good place to look for it, because then Section E is going to look at their behavior issues. And remember that because these are not done on an all-time basis, some of the daily monitoring that is actually done by nursing maybe reports may be adjusted to help eventually fill in the MDS when it's need to be done. So a lot of this information should be collected in the chart on a daily and constant basis. Functional status, section G. I'm scrolling through here. Here's bladder and bowel. Here's where you can find truly what their active disease diagnoses are. Granted, once again, this can be updated in between reviews. Notice pain management is a big issue, and so some of these issues that are in here may not be directly related to pharmacy, but because medications are used to treat these conditions, pharmacy is part of that. Here's we got tobacco use, so we may be involved in tobacco sensation. Here are some of our issues such as falls, under health conditions, swallowing issues, weight loss issues, dental skin issues. I'm scrolling down to show you where actually pharmacy is. Section O is about special treatments like chemotherapies, whether or not they actually need any type of restraints to prevent falls or behavior issues. I missed it here. Hold on a second here. Section O used to be where we talked about medications, but hold on a second here. They updated where medications are from the time. Here we go. All right. Oops, that's section J. Here we go. Section N it is. So section N, it used to be section O. But section N is what the surveyors get in terms of what issues are with medications. And although everything applies, especially what we talked about in FTAG 329, here is the issues that they're looking at. They're looking at number of days of injectable medications received, and they're not talking about IV medications for antibiotics. They're talking about injectable medications such as Haldol, maybe IV Ativan, things that might be used for behavioral issues. Checking all medications, so they're looking at antipsychotics, anti-anxiety, antidepressants, hypnotics, and then the other one they're looking at is anticoagulants. And that's all that gets recorded in section N. Like I said, unnecessary medications can fall into play, and if there's anything of these medications affecting any of these other conditions in the MDS. But remember, these are the key ones they're going to look at every time they come in for the survey process, and we'll talk about them a little bit more in the quality indicators. Okay, let's get back to where we were. So the other thing that goes on in the home is there is what's called the resident assessment instrument, and this is data collected in the MDS is utilized to create a resident assessment protocol, also known as the RAP. And this provides the foundation in the creation of a resident's individual care plan. So, for example, say in the MDS we identify a patient has fallen numerous times. Well, then there should be a care plan of pharmacist reviews medications to make sure they are not on anything that puts them in high risk for falls. They may need to use bed rails to prevent falls. They may have to use special shoes with special footing in them to prevent falls. And so that is what the resident assessment instrument that comes out of the MDS. And like I said, the MDS triggers any risk potential that should be addressed on the care plan. All right. Now, one of the things that can occur because these are done every 90 days once the initial is done, is that I usually as a consultant would ask for the resident change list from the MDS. And so if there was any of these issues that flagged that were new for a resident, my job was I reviewed the resident to make sure no medications or causing those conditions. Because it's real important to remember, and this comes from a famous geriatrician physician, Jerry Averon, and he writes this: most of the nation's medical students finish their training without ever having stepped foot in a nursing home. And the dearth of training in practical pharmacology for most graduates, the proper use of medications of the frail elderly patients becomes the overlapping of two voids, creating a particular dense black hole in their clinical knowledge. So a lot of times you're the staple there at the home as the consultant. You're the expert in geriatric pharmacology, hopefully. You're the expert identifying if could medications be worsening any of their conditions based on the MDS and the resident assessment instrument. There's two stages of the quality indicator survey. The first stage is preliminary, investigates all regulatory areas and determines care areas for the in-depth Stage 2 review. Stage 2 determines if deficient practice and document deficiencies include FTAG scope and severity. So what all does that mean? Well, in Stage 1, the MDS sample that the surveyors will draw off-site and include all residents with an MDS assessment within the past 6 months of the survey. They'll take a random sample, and they'll take a random sample of new residents that were just recently admitted. They'll actually do some resident interviews. They'll do resident observations. They'll do staff interviews. They'll do medical record reviews. So here's where they're looking at good documentation, whether or not we're doing any dose reductions with psych medications, whether or not physicians are following the recommendations, is there any unnecessary medications, is things being properly monitored, and they'll do family interviews. The other thing that'll occur, they'll look at observations of dining and kitchen. They look at everything from the temperature of the food to obviously the prep of the food. They'll look at infection control. They'll look at their billing procedures, and they'll look at the notes of the quality assessment insurance program. Then that on-site data is combined with the MDS to create a resident-centered outcome and process indicators, and from there they will do a sample review of a recent admission. They'll look at all the different issues that might be occurring. They'll look at infection control. They'll look at how policies and procedures. They'll look at technique. They'll observe hand washing. Stage 2 sampling occurs when the computer identifies samples that all triggered areas that might be an issue based on the MDS. They'll also look at any sentinel events and complaints. We'll talk about what a sentinel event is. That is something that could put a severe harm to the patient that could occur, and any filed complaints from residents or family members. At any time, the process surveyors can initiate the addition of more residents, more areas to focus, and more FTAGs. And usually if they find something wrong, then they may go digging for more. They'll do a MedPass observation to see how well, and that is why we do sample med passes before a state inspection would occur. They'll do a 10 resident sample of medications. They'll look at how they're being prepared, how they're being administered, how they're being stored. They'll look at the staff's knowledge of the medications, and they'll look at, how well they're assessing medications. So this is the overall of the MDS. This is the overall the survey process, and then based upon what they find, do they necessarily fine the home or charge the home with anything? Not necessarily, but they may, depending upon the severity of the infraction, they may ask, most of the time they'll ask the nursing home to come up with a plan of correction, and they'll have so many days post-survey to come up with that, and the home will then have various monitors throughout the year to make sure that whatever was the infraction is improved upon. You as the consultant pharmacist, especially of medications, you may be involved having to do additional nursing in services, additional monitoring for the home, and also just your knowledgeable input in how to do those plans of correction. Like I said, the worst case scenario is there can be, and I talked about this in the initial intro long-term care talk, is there can be dollar sign fines in a survey process. There can be the worst fine where they can shut down new admissions. And then the second and the most important worst one is they shut down the home completely. So this is the overview of the MDS. Please take time to look at the recommendation, the MDS form itself. This is something that when you go to a nursing home to consult, you'd ask them where the location of this is. Sometimes it's located online. It's not necessarily always in the chart. Sometimes it has its own binder. And the other talk that will be posted is the quality indicator talk, so please look for that online. And I will talk to you next week in the chat session. Thank you.